He's back. We cannot get enough of him. Dr. Adam Cifu is back on Healthcare Unfiltered. And, it's great because not only I learn a lot from Adam, but I also have been a big fan of his prior podcast, Symptoms to Diagnosis, which I really urge everyone to listen to. But today's episode is I wanted to bring Adam on to talk about his new adventure and what he is actually doing on and why and what's the platform. And I'll try to push back because you know me, I have to push back. I cannot always take things, Adam, well, welcome back.
Thank you very much. Chadi, you are a gentleman and a friend. I'll agree when you ask me to be on. And when I call you and say, hey, I want to pitch a podcast, you're like, sure, come on back.
Yes, well, because I've seen your production. I've heard your production. I didn't see it, and I certainly, if you're coming up with something new, it is absolutely something that I wanna learn about and tell people about. But before we do that, to set the stage, tell me about the previous podcast, Symptom to Diagnosis. What brought it on? And what are the lessons learned? Because, I presume whatever you've learned from this, you are going to incorporate differently in the new adventure.
Sure, that's a great question. So, so the last podcast, which was called S2D, the Symptoms Diagnosis podcast, I did with Scott Stern. And what sort of instigated that is that, Scott and I have worked for years and years and years since, I think, 2002, on the Symptom to Diagnosis textbook, which we originally wrote with Diane Alcorn, and then over 4 editions transitioned from really authors to author editors. And as everybody's used to, there are people who love textbooks and there are people who don't love textbooks. And I'm a huge podcast lover. Obviously, there are people who said, boy, we'd love to hear this. And so Scott and I put aside 39 hours to record episodes about each chapter, plus a few more of the textbook. And so those were all episodes around a symptom. So chest pain, hypotension, joint pain, whatever. We organized those around a single case with sort of an expert and somebody trying to figure out the case. And then we wrapped them up with, see if I still remember, with pet peeves, random pearls of knowledge, frequent misconceptions, and I don't know, other keys or something. And it enabled us to both articulate our clinical reasoning as we work through a case, plus sort of provide some really clear facts about each diagnosis. We thought it would be a hit with medical students, and we are really happy to hear that besides medical students, it was very popular with physician's assistant students, with nurse practitioner students, and then with residents and even some senior clinicians who were like, it's kind of nice to listen to a 30-minute test of my knowledge, and I always come out learning a few extra things. So we loved it.
Hey, I mean, I'm a board certified hematologist and oncologist, and I loved it. I actually, what I loved about it is you have good chemistry. It was very obvious. Like you can, you joke a little bit, you kind of try to stump each other a little bit with certain things. So I love that. And I like the dialogue piece. So how was the reception of that? Like, were you able to get some feedback?
We really did. It's as first, I think how important the chemistry is, right? There are some people that no matter how you try and how well you prepared are, it's just difficult. Scott and I are friends, so that made it fun. And I think a lot of that came through. It's hard with podcasts because often you feel like you're just kind of talking into the ether, right? Or releasing bites into the ether. But we actually got some really nice feedback, both as far as reviews, certainly as far as downloads, but also on Twitter, on emails. And Scott and I were lucky enough to be, invited to a bunch of grand rounds and things like that to do together, because people were like, wow, we love how you guys work through cases. We love hearing you work together. Is there a way that we could make this live? And some of them were just fun. Some of them were a little bit scary because they had us figuring out cases that we had no right to be trying to figure out. But I think we enjoyed it. And my hope is, which is harder, is that I'd love it to kind of have a life of its own, right? Where it gets sort of pitched to every new class of medical students going into their medicine clerkship. And I'm trying to figure out a way to, to keep it fresh and sort of repitch it every year. And I don't know, I'll work on that.
And do you make money out of this podcast?
Of course not.
No. But you know why I say that? Because I also don't make money out of podcasts, but I think it's a labor of love. I really think that when you do this and spend hours and you're not making a dime of it, I mean, it's really people who do that, they love it, I think, because I think
you and I are both educators. I spend a lot of time, or have over the last 25 years, sort of at the medical student level. You've been at older, more advanced level, something like that. But this is just, teaching in another way. And I love this. It's like another creative outlet.
I think to put me in your category is huge compliment to me, maybe an insult to you, Adam. You're in a way different class. Since we were faculty together at University of Chicago, I truly always had a lot of admiration to you. But
thank you.
So at least this means that you had no issues, that you decided to keep podcasting. So what's the new gig?
Crazy, right? So I with I don't know, a clear horizon to my career. I've been lucky enough to sort of think about, what do I really want to do over the next, 5, 6, 7 years, that I'm sure I'm going to be doing this. And part of that was to take a position here with the Bucksbaum Institute for Clinical Excellence, which is really a wonderful group that's been working for about 10 years. And they've done some terrific things at University of Chicago by both recognizing clinical excellence really at all levels, and then to try to mentor people really from the undergraduate years through medical school, to teach people about how important the doctor-patient relationship, the sort of practice of medicine, in capital letters, is to the future of medicine. And the Bucksbaum Institute is interested at this point to try to get a little bit more of, let's say, a platform, outside the ivory towers and outside of University of Chicago. And that's going to be with journal issues. We have an upcoming supplement in academic medicine. It's going to be some funding outside the university. It's going to be offering some teaching seminars outside the university. And we thought that a really interesting place to go would be a podcast that is really dedicated to discussing issues around clinical excellence. And the way we chose to do that is to speak to physicians about really difficult topics that we all struggle with, to talk to patients about their relationship to the healthcare field, and then to also talk to some research who are doing what we call Bucksbaum adjacent work, sort of work in the sphere of studying the doctor-patient relationship, of studying interventions which may be able to improve that kind of the clinical care that's delivered by physicians outside of the trials of a new drug or a new procedure or a new diagnostic test.
So the idea is to get more people aware of the mission and vision of the Institute,
Yeah, I think to get people aware of the mission and vision, but it's kind of not about us, right? It's trying to improve clinical care on a grand scheme. And so the hope is that if I can sit and have a conversation with someone who is really a pro at breaking bad news in the surgical realm, or has thought a lot about terminating care with patients, or has put a lot of efforts into, how do we address physician burnout, and have a conversation with those doctors, which then doctors, patients, interested lay people can listen to and get more of a sense of, how medicine should be, that maybe we benefit, doctors and patients, on a much wider scale than we have in the past. That may be
Yeah.
grandiose, but
No. I like the idea of I mean, what I'm learning is you want to pick topics that are rather challenging
right,
in clinical care,
right,
and you want to bring an expert and have a dialogue with that expert about
right,
that challenging problem. What
right.
I'm trying to link to listeners is, how do you bring the institute into this? Because you could have the same thing in a completely separate podcast, and you say, you can call it
Absolutely.
clinical care, whatever you want to call it.
Absolutely. Absolutely. So I think the way Bucksbaum fits into this is that the Bucksbaum Institute, one of the things that they have done over the last 10, 12 years has been to recognize junior and senior faculty as what they call Bucksbaum scholars. And these are people who, through colleagues, through patient feedback, are sort of recognized as really just doing an excellent job in their clinical work. Okay. And then where I'm lucky is that I have this sort of panel of physicians that I can look to and I can say, here's an interesting question. And, Chadi, these are the questions that you and I just pop into our head all the time. One of the early episodes is to think about those patients who come to you for a second opinion. And the second opinion that you're offering is pretty much what the first opinion was. And it's not really what they're looking for. They're hoping to hear something different. And that those can be, difficult interactions, right? And to find a physician whose practice has been, recognized by the Bucksbaum Institute, and ask that person to come on and say, hey, this is a hard issue. This is a hard visit for physicians to navigate. And it's also a very difficult position for patients to be put in. Geez, I've waited a month to hear what this next doctor is going to hear because I wasn't happy about what I heard from the first doctor. And damn, I heard the same thing from the second doctor. And to have a very open conversation about that. The Bucksbaum Institute was very excited about this. I have to say, I think they were a little bit hesitant because it's like, oh my God, you're going to talk about, terminating patient relationships on our podcast. But I want to do is I really want to parlay the knowledge and the expertise to some of the more difficult issues.
I thought you're going to tell me they were like, oh my God, we don't know. We can't control him. We don't know what he's going to say on the podcast. We need to censor them.
Come on, I am very careful.
Yeah. So let's maybe give listeners some examples of the topics, because I mean, do you have those, for example, outlined already for the next year? Is going to be every 2-3 weeks, and how?
Sure.
What topics from the physician perspective?
Sure, I can tell you. So, as I said, we'll be releasing these about every other week, and they will be 3 formats. And when we think about the physician-oriented ones, some of the initial things we're going to be talking about, a couple I already mentioned. We talk about terminating care with patients. We talk about burnout. We talk about giving unwanted second opinions. We talk about breaking bad news in a surgical practice. We're going to talk about caring for colleagues. We're going to be talking about caring about, the VIP, that supposedly very important person who maybe is bringing a lot of money to the institution, what challenges those raise. We're going to be talking about balancing public advocacy with patient care. We have a great episode, which I've already recorded with a psychiatrist, about countertransference in the patient-doctor relationship, and taking countertransference away from being an issue in psychotherapy to how it just happens in a visit between an internist and a patient, or an oncologist and a patient, where we have strong reactions to an individual. And does that get in the way maybe of how we can care for this patient and how we need to be mindful of that? So those are some of the initial conversations that we've either recorded or have on the books coming up soon.
And by the time actually folks are listening to this podcast, few of your episodes would have been released. We are, for transparency, we are taping this before the first episode is released. But by the time this is out, few episodes will be released. And you've been very generous. You actually sent me a pre-recorded short episode, which I really thoroughly enjoyed. Are all of these episodes going to be like 15, 20 minutes in length?
They are actually. We've sort of put an absolute limit of 30 minutes. And as we've been recording them, most of them are around 20 minutes. And to tell people, what the prep is for these is I've been sending the physician or the patient who's coming in just 3 questions. And I say, I don't want scripted answers, but this is just to let you mull this over so you have some thoughts before we go into it. And certainly 3 questions ends up being a little bit more than 3 questions, because there are follow-up questions and sometimes the conversation gets going a little bit. But I found that generally ends at about 20 minutes, because there are a lot of great podcasts out there which are really deep dives into people and their thinking, one of which is yours, to be honest with you. And what we're hoping to do is to say, look, dive in here, a few high-level thoughts about a single topic, and then get out of there. And we think there are enough really good, thoughtful medical podcasts out there. So as we try to figure out, what's a niche that we can fit in? I'm a huge podcast listener. I don't want to replace any of the podcasts I'm listening to, but if there's something that I can add on for, like, oh, look, here's 20 minutes while I'm washing dishes, I'm happy to do that.
And here's, I think, what intrigued me when we first talked about this, where I really think it's very, very different, in my opinion. First of all, your original podcast, Symptoms Diagnosis, was clearly different. It fulfilled a niche, and I enjoyed it. What I found a little bit intriguing in this new gig of yours is that you are going to bring patients.
Yeah.
I don't see that often.
No.
And I want to ask you a little bit about this. How easy is it to identify a patient, first of all, and then to bring a patient? And it can't be that easy, is it?
It's not that easy. And as you say, as we're recording early, I've recorded a few of these episodes. And I think probably by the time this podcast is released, your listeners will be able to judge how successful they think this idea is. When I thought about this, there were a handful of patients who immediately came to mind, who I know I've had as part of my clinical care of that patient, really rich conversations about how they think about medicine, and whether it's how they think about being cared for as a physician by a physician, if they see the failure of doctors in their ability to communicate, if they see issues with healthcare disparities and are happy to express those, that those are people who immediately jump to mind, who I could approach and I say, hey, we've had this conversation. Would you be open to having this publicly? Because I think people could really learn from you as a thoughtful receiver of healthcare. My hope is that over time, and that after I get a few of these out, that I think most physicians have a handful of patients who would be open to that. And those discussions will either be between me and that patient, or will be between, that patient and their own physician. and we'll see how that works. But I think, we for decades now, right, have thought about medical care through the lens of shared decision making. And we spend so much time thinking about the doctor side of it, and how we decide on what diagnostics and what therapeutics and what interventions we're going to do. And we know that we bring that to the table, but we also know that we have to hear from patients about, not only their values, but their knowledge, because patients bring so much knowledge to the table these days. And it would be wonderful to get that side of the conversation on, a medical podcast.
So you could bring like a guest physician, for example, and his or her patient, and they can have the conversation. Yeah.
Absolutely.
So are there topics off limit? I think that we live in a weird environment right now.
Yeah.
And, you've been on my podcast with the title Cifu Steering Trouble, because we know you're a troublemaker. But, like, are you going to talk COVID?
Yeah. I don't, you know me, although I stir trouble, I think of myself as being someone who's pragmatic, someone who hopefully is not terribly divisive, because maybe a bit of a flaw of mine is that I tend to be somewhat paralyzed by seeing, both sides of an issue. So I think there will be some touchy topics. We do have an episode planned about, navigating political differences with patients, for instance. But I hope that what we do is we do a good job just sort of laying the issues on the table and saying, look, this is a way to navigate this in the room with a patient where, we're there to do what's best for the patient, right? That's our oath. That's what we're trying to do. And therefore, I don't think much of what we're going to talk about is really going to anger people. I could always be wrong. By the time this is on, I could be canceled, and you'll have to do away with this.
I think it depends on the topic. I do think that it, to your point, Adam, you're very pragmatic, and these are really issues that do occur, and you could be at the complete spectrum of the political divide. You could be very left, for example, and you walk into a room and meet a new patient who is clearly very right, either however you really are able to decide that. And really the question to your expert would be, how do you get the emotional aspect of this? Because there is no physician out there, at least in my opinion, that wants to harm anyone. This is the oath that you take. But the emotional aspect becomes a little bit difficult. So it's not like you are going to prescribe a wrong therapy.
Right.
But you could be less communicative.
Right.
You could just want to get rid of you want to just finish the visit faster. If I call you after hours, you may not always respond to me. Like, these are the things. You're not going to give me a wrong medicine.
Right.
But the way you interact with me
right.
may be less than ideal.
Right. And I hope, and I think this is going to be the challenge, but I'm fortunate that at least thus far, the physicians that I've been interviewing for this, and I think I'm doing this on purpose, I am choosing people who are quite experienced, quite, let's say, comfortable in their own, medical practice skin, and so are really able to admit their flaws. Because, look, do I think I'm a perfect doctor? Absolutely not.
Yes, you are.
No, do I understand where I fall short? And it's a lot of the things you talked about, right? Are there certain patients who I'm like, that's going to be a hard phone call. I'm going to put this phone call off. Do I treat all of my patients exactly the same? No, I don't, because I'm human. And I want people to be able to express that, to talk about that, because I think we can benefit from those conversations. Because often it's having that mindfulness and understanding, where you fall short, why you fall short, which is helpful, or to discuss those really hard topics that are hard for everybody. But so the next time you're thinking about a patient saying, wow, I've lost my affective neutrality here. I'm not sure I can care for this person anymore. To say, is this the right thing to do? Am I biased in the patient's, whose care I need to terminate? Is there another way I can approach this person? That really can probably help everybody in a way that's far beyond what you learn in patient doctor one or advanced communication skills in medical school, which is probably the last time that a lot of us have actually been taught this stuff.
One topic I wonder if you considered, I was thinking about this, is the discrepancy between how physicians believe they are effective in communicating and whether patients really even hear what they are saying.
Yeah.
I don't know how you would do that without simulation. It's very difficult to do. But, the classic example that we often use where the physician feels that they're totally controlling the pain of a patient and the patient is in agony and in pain. Have you thought about the contradictory perception of both sides?
I love that idea. It's funny. I've thought about that a lot, but not in terms of this podcast. And so I just jotted it down as you say this. Where I see this so often is my patients with chronic pain who I've referred to another physician to help with their chronic pain, whether it be a pain specialist or an orthopedist for joint pain or whatever. And that physician has done an excellent job. They've done an intervention for the pain. They've seen the patient follow up. They've asked, to what percent is your pain controlled? They've documented that, right? And then I see the patient and I'm like, oh, I'm so happy to see that, your back pain is 90% better. And the patient's like, what the hell are you talking about, right? And maybe the thing to do is to actually bring that doctor and that patient into the podcast to have a discussion and to say, look, you've been working on this patient's pain. You've been doing kind of yeoman's work on this, but your impression of relief is different. And it's not just the doctor not listening, right? It's often the patient feeling like, I don't want to hurt this person's feelings. I want to make them feel like they're doing something. They're really complicated conversations.
But if you can somehow figure out how to do this, I just think it will require a physician who is very confident and comfortable in his own skin. And that's why it's not going to be a junior faculty. Their self-confidence will be, but I really think many of us would be willing to do that because nobody is perfect, and there's a variety of reasons why there's this misalignment. How about caregivers? Are you thinking of bringing caregivers into some of the podcasts?
It's interesting. So in some of our discussions in the kind of brainstorming at the beginning of this, we had talked about that. And right now I do have one person on the schedule who is someone who is not my own patient, but was a caregiver to my patient. And I'm very excited to have her on to discuss not only what it was like, caring for her spouse, which was very difficult, but what it was like to be at the visits with me, sort of in a three-part relationship. That's all I have planned to start, but I think it's sort of a rich vein to go after, and maybe depending on how that conversation goes, and I'll probably be after this conversation be picking your brain, about what's the best way to go after that, how to have patients on, what sort of environment to have them in, to get their caregivers involved.
I did one episode on caregiver burnout, and I think that is something that is really important. At least in oncology, I saw this a lot because it's all about the patient who has cancer, and the caregiver feels guilty. I mean, he's the one or she's the one getting the chemotherapy and the treatment. Who am I to complain about? But I think this topic will be interesting to think about. Let me ask you also another question. Are you? I think we're talking just general topics. Are you going to tackle administrative topics? You mentioned burnout, so you intrigued me a little bit, because we all know that sometimes the burnout of physicians stems from the administrative tasks and EMR, all of the good stuff. These could be sensitive topics, especially given your position and being a faculty member. So, how are you going to navigate that?
Yeah. I have to say I don't have any what I would consider like administrative topics on the list, but I think as you frame it, it's very much the case, right? That there are things that affect the life of physicians and the life of patients that come from not the care we deliver, but how we deliver the care. And we, meaning just not just me as a physician, but the institution where I am. I'm not, and I've already seen that come up in conversations with patients where I get the, oh, my doctor's wonderful, but, and talks more about the hassles of care delivery. I've been pretty comfortable with that so far because I never feel like I'm, disrespecting my institution. I feel like these are pretty common issues. I don't know any doctor who works anywhere who doesn't struggle with the environment they're in. And so I think, although we're not going to be anonymizing it, I think these will be universal struggles. I think everybody, complains about getting to their doctor to communicate, getting an appointment when they want to get an appointment, working with physicians, staff, nursing who are not always as sensitive and thoughtful as caring as they want. If that was only a problem at one institution, it would be an easy fix, right? We close that institution.
Yeah. I have to tell you, the idea of the podcast, as I just listened to you, there's so many ideas come to my mind because it's so rich, right? I mean,
yeah, it's right.
You practice long enough, you can think of so many things that you can bring from a patient perspective and a physician perspective. So I love that you're going to bring both views. Are you going to alternate, like 1 week patient, 1 week physician?
So far, the easiest and the richest source has been physicians. As you say, and it's one of the things which makes this attractive to me, especially after our last podcast, because S2D was sort of, okay, look, we got 37 symptoms we want to cover. We've covered those. Obviously, we haven't taught all of medicine, but we feel like it's a good start. There's not a week that I don't add something else to my spreadsheet as far as another topic. I think this can go on forever. So far, the easiest things, therefore, have been to say, wow, this is a great topic. And the doctor who I want to talk about this with comes to mind almost immediately. I think the patients will be a little bit more work, just finding the right person, finding a doctor with the right person. So I bet those are a little less common. And then Dr. Matthew Sorrentino, who you know from your time at University of Chicago, senior cardiologist here, who's done a lot of work at Bucksbaum with assessing applicants for pilot grants in the sort of clinical excellence realm. He's going to be doing a lot of the interviews with PIs and study authors. And so I think we'll be seeing those probably about a third of the time as well.
Well, I'm taping this before. I only listened to a pilot one that you shared with me, but I'm definitely going to be a subscriber and a listener. And I would love everybody who's listening to this to try and listen to it. Any other things you want to share with listeners or the team?
I was going to say, just to get you on the record, I expect you to not only be a listener,
Oh, I'm going to rate it.
But for someone, no, I was going to say, for someone who's going to help me with the brainstorming for the list, and for a guest on a topic in the future, something something appropriately difficult for your level of experience. So prepare yourself.
No, it's gonna be great. But what else do? Well, hold on. The most important piece. Have you picked your music?
Yes, we have picked our music. Our music for the S2D podcast was from a hospitalist colleague of mine, Dr. Malin Martinez. People who listen to that podcast will recognize me saying the music for the S2D podcast is courtesy of Dr. Malin Martinez. And she is back with another piece for this podcast. I think it sounds terrific. And we have a wonderful sound engineer who's also picking out very rich comments as sort of teasers for these. So I'm pretty excited about the way the podcast sounds.
Well, you definitely have the best sound. Before we went on the air, I did ask you have to send me the information about your microphone and all that, yeah, because I'm getting jealous here. What else could we share with folks who hopefully by now are listening to this, but if not, hopefully they will do that and they rate it, subscribe to it. And is it going to be on YouTube? Are you going to do visual as well?
It won't be. It'll just be on podcast channels. As they say, you'll be able to get it wherever you get your podcasts. And I will be relentlessly pitching it both on my Twitter feed, that's at Adam Cifu, and there's a Twitter feed for the Bucksbaum Institute. It'll be showing up there as well. So please do, download a couple of episodes, and if you like them, please subscribe and follow along. And both through my Twitter feed and through the Bucksbaum Institute's Twitter feed, we are so open to suggestions about topics. I hope this is something which goes on for years, and we will really entertain anything that people throw out there and want us to talk about.
Judging how healthcare is, it's going to go on for years, and I don't know what happened. I don't know what happened to my picture right now, but hopefully I'm back.
You're back.
Anyway, Adam, this was great. Congratulations on the new initiative. I'm really very, very happy for you. And then I wish you all the success. I mean, I know that's going to be very successful, but I look forward to be amongst your first listeners.
Right. Chadi, thanks so much. It's always a pleasure to talk to you.
We'll amplify it all together.
Take care.
Thank you so much.